see the algorithm of esophageal varices bleeding. So this is a upper gastrointestinal bleeding. Is the most the one that has more mortality of all. The gastrointestinal bleeding. This would present most of the time in a cirrhotic patient. The bleeding of esophageal varices is not painful. It could be spontaneous or after any effort. The patient would present with, most of the times, either coffee ground or coffee ground emesis or hematemesis. Yes, in rarely cases, the upper bleeding can go to the lower gastrointestinal tract and can present with hematochezia if the blood is going too quickly, or with melena. But we will think as coffee ground emesis or hematemesis, for example. This is blood on the vomit. That's hematemesis, and coffee ground is blood with a not bright red but more like brown going out of the mouth. So after examining the nose, etc., then first step is to put 2 IV bore lines to initiate fluid resuscitation. Now the fluid resuscitation would be, this patient is bleeding, so the patient can have signs of shock. So this patient could be unstable. We would give fluid resuscitation until the patient is stable. That is, when the heart rate becomes less than 90 beats per minute, when the systolic blood pressure be below 100 millimeters of mercury, or the diastolic blood pressure being less than 90 millimeters of mercury. Then we need to give antibiotics. This includes ciprofloxacin or ceftriaxone. Remember that in every patient with esophageal varices bleeding, we need to give the prophylaxis for spontaneous bacterial peritonitis. Then we will give octreotide in order to decrease the vasodilation of these splenic vessels. So there are a lot of hormones like glucagon that promote the dilation of these splenic vessels, doing a third spacing, etc. So if we give a octreotide that is analog of somatostatin, we're inhibiting those vasodilator hormones. As in the past we used the vasopressin, but now it's not used anymore due to less effectiveness and side effects like cardiac side effects. We need to monitorize the patient for delirium because this cirrhotic patient could be an alcoholic patient. We need to assess the probability of rebleeding, so we need to be monitoring this patient in the intensive care unit. The increase in rebleeding is most commonly seen in patients with either a clot on the esophageal varices or red streak or a bright red spot. With this we should be very cautious about the rebleeding, and in given case we can give fresh frozen plasma. We need to monitor the PTT. If the hemoglobin is below 7 grams per deciliter, we need to transfuse a pack of red blood cells. This is the acute management. If this bleeding stopped spontaneously, then we need to do ligation of the band ligation. This will be the secondary prophylaxis, because the primary prophylaxis is to a cirrhotic patient we will give propanolol. Yes, certainly we will give propanolol in the acute management, but after the patient is stabilized, so after doing all this. Now, 2 weeks later, etc., we need to band ligation in order to prevent a second episode. So this would be secondary prevention, and if we cannot intervene the bleeding because the acute bleeding is treated, it could be surgical, but if we cannot treat it in the moment, then we can do a temporary tamponade of the bleeding varices. This is with a Minnesota Blackmore tubes. These are just temporarily put in order to transfer the patient. Could be, for example, to a hospital, from a hospital to another, something like that. If the patient is not able to do, or we are not able to do this in this patient, then we proceed to the tips. Transjugular intrahepatic portosystemic shunt. And remember that the most common side effects of this, or most common complication, is the worsening of the hepatic encephalopathy. The last treatment would be to prevent the secondary esophageal varices with the band ligation. No, the band ligation is the most commonly used method, but also we could do sclerotherapy. But this can lead to strictures and scarring, so this is not the best step. The best step would be the band ligation. Now, in the next video, we will talk not only about esophageal varices bleeding, but the complete upper gastrointestinal bleeding.